Thank you very much. So I would like to start with our chronology. We start with the program of liver laparoscopic resections in 2010. 2010, even the first liver resection was in 2005, but the real program started in 2010 when I performed my first personal laparoscopic resection. That was a left lateral sectionectomy. And short in the history, we start with re-hepatectomy in the patient number 21, and it was after 30 patients that we start with major liver resections, and so on until now. That our final step was to reset laparoscopically patients operated before by open resection. So this is our annual case load, starting from 2010, when the ratio from open to lab was 8:1, till the last year in 2014, when we reached mainly half of patients operated by laparoscopy. And currently, we are performing more patients laparoscopically than by open. This positively compared with this very recent contribution from a survey in a well-known laparoscopic country like France, when they analyzed the implementation of laparoscopy during 5 years, from 2007 to 2012, and the percentage of laparoscopic liver resection was almost the same in this 5-year period. And if we see for the annual case load in all the hospitals of the public service in France, as much liver resections are performed, the less that implementation of laparoscopic resections are done. If we're looking our numbers of between 60 and 70 hepatectomies per year, we are in this group, and we are far from these numbers. Here I would like to show our 212 laparoscopic resections performed in these 5 years, mainly in male patients. And in the same period, we performed a little more than 200 open resections, mainly with colorectal liver metastasis as the indication. Only 10% of patients was operated by benign situations. And we mainly perform segmentectomies or wedge limited resections. Taking into account, we have 15 resections of the posterior segments, 3 patients that we perform redo hepatectomy, 3 simultaneous resections with gastric and colonic cancer, and in 11 patients we combine radiofrequency ablation with liver resection. Our rate of conversion decreased from the initial years towards our currently 6% of conversion. But the time, the surgical time remained stable during time. It's our policy to clamp selectively, but around 80% of the patients need inflow occlusion for complete liver resection, and the blood loss are discrete. If we look for morbidity, we purposely register all the morbidity, so our morbidity is 35%. But mainly, almost 90% of the patients, this morbidity was mild if we use the classification of Dindo, and mainly being grades 1 and 2 morbidity. The rate of reintervention was low. Our median hospital stay is 4 days, and our rate of readmissions is low as well. We only have one mortality case. There was an 82-year-old male that we performed a right hepatectomy after portal vein embolization and after a course of neoadjuvant chemotherapy with follow-ups during 4 months. Perhaps it was now a good indication for liver resection. Our preliminary data with the first 50 resected patients was published last year, and we can show the same numbers with a 36% of mortality, and we can observe a reduction of the surgical site infection compared to open patients, and in a reduction in near 3 days of the hospital stay. So I would like to conclude that introduction of laparoscopic liver surgery was done faster in comparison to the literature, that morbidity and mortality is within the standards of care, and far from the consequences of the learning curve in terms of morbidity and mortality, we experience a significant reduction of infective complications and hospital stay compared to open surgery. Thank you very much.